Hello, it's Dmitry again, doing another video today from Blueprints Psychiatry Chapter 10. This is going to be the chapter on special clinical settings. Now again, this is going to be from the 5th edition of the Blueprint Psychiatry textbook. There's a 6th edition that's out there that's more updated, so bear that in mind. But we're reading from the 5th edition right here, again, the chapter on special clinical settings. Starting off with, and I think I could probably get away with saying this on YouTube, I don't get very many views, suicide attempts. Which on TikTok and YouTube they call that unaliving attempts, but apparently. Anyway, so suicide attempts, neural basis. Emerging evidence has begun to reveal neurobiological contributors to suicidal behavior. There is a considerable evidence that low central nervous system serotonin is associated with increased suicide risk. Altered serotonin markers include reduced cerebrospinal fluid serotonin metabolites, reduced brain serotonin concentration, and altered serotonin receptors. Genetic influences have not been thoroughly explored, but the concordance rate for suicide in monozygotic twins is nearly tenfold that of dizygotic twins. Alterations in the tryptophan hydroxylase gene, a key enzyme in serotonin synthesis, have been associated with suicide risk. Epidemiology. Suicide is the 8th leading cause of death in the United States. Approximately 80 people commit suicide each day in the United States, 30,000 per year. Many more people attempt suicide. The overall suicide rate has remained stable in the United States during the past 15 years. Although the rate of suicide in teenagers aged 15 to 19 is low compared with the general adult population, the rate of teen suicide has risen dramatically in the last 50 years. That's interesting. Interesting in an unfortunate way, but nevertheless. Risk factors. The overwhelming majority of people who commit suicide have a mental illness, most often a mood disorder or chronic alcoholism. The first-degree relatives of people who have committed suicide are at much higher risk of committing suicide themselves. Gay and lesbian youth have 2 to 3 times the rate of attempted suicide compared to heterosexual adolescents. Now, I want to make a little bit of an aside for that. They say that in isolation, and they don't seem to make any sort of attempt to connect that to any sort of other factors at play. The general intuition by people, at least contextualized in our society, is that because gay and lesbians are bullied or something like that, and they're not accepted by society, therefore they kill themselves. That probably plays a part, certainly. However, it also should be said that people, at least certainly both, I would say both the men and women who are homosexual identifying, they are more likely to have other concurrent mental illnesses. And so that is also going, and that's also, by the way, partly genetic and partly environmental. In many cases, they have higher rates of, and certainly in homosexual men at least, I think, they have higher rates of alcohol use, illicit drug use, they have higher rates of smoking, for example. So they have higher rates of substance use and abuse. And so it's not really a surprise that people who are higher rates of mental illness and higher rates of substance use and abuse are also have higher rates of suicide. And there might be some underlying genetic predispositions or environmental predispositions, like how they grew up or hormonal influences potentially, that might provide this overall presentation in terms of their psychology and their sexual psychology as well, that's interconnected, and not simply, oh, I'm just arbitrarily gay, I'm just arbitrarily as a man attracted to other men, and so arbitrarily I'm bullied by society for being gay, and then I killed myself. That is not really, that's kind of extremely reductionist, and in many ways I would say a distorted understanding of how these things interact with each other. Anyway, nevertheless, let's get into it. Let's go back to where we were. We were talking about, yes, okay. So suicide risk increases with age. In men, suicides peak after the age of 45. In women, most suicides occur after the age of 55. Elderly individuals account for 25% of the suicides, although they represent only 10% of the population. Overall, men are more successful at completing suicide, perhaps because of their more lethal methods like shooting, hanging, jumping, Again, see, they want to explain it that they say, oh yeah, here's the explanation here. These are very obvious reasons that men actually are trying to do things that are very lethal, like shooting yourself. Compared to women, they consume a bunch of tablets, and then they go to the hospital or something like that, basically. Not that I would also be interested in. They don't have it here, but I would be interested in what are the rates of threatening suicide to other people, because there are people who threaten suicide to people they're in relationships with. There are women who do this. There are men who do this as well. And I'd be interested to see if that is broken down by gender as well, and if there's any sort of relationship between how lethal are their suicide methods versus their willingness to just threaten suicide, potentially just to kind of like psychologically blackmail people into compliance. I'd be curious about that. Anyway, men commit suicide about 4 times as often as women do, whereas women attempt suicide about 4 times as often as men. So basically, women are way more likely to attempt suicide, but men are way more likely to actually successfully commit suicide. So 4 by 4, basically, that's interesting. So women are 4 times as likely to attempt, men are 4 times more as likely to commit. So there's a 1 to 16 ratio between the success rate apparently for women. That's crazy. Anyway, so women are way more likely to attempt, but they just aren't successful most of the time at all. Wow. Now that's a good thing that they're not successful. I'm just saying, there's a very obvious disparity between the two. Women often overdose or attempt drowning. Married people have a low risk of suicide than singles. Suicide is more common among higher social classes, whites, and certain professional groups. Physicians, dentists, musicians, law enforcement officers, lawyers, and insurance agents. Now, going along with that as well, I think I would say East Asians also have a higher suicide rate. I know American Indians, I think, have deaths of despair that more related to like alcohol and drug abuse rather than suicides per se. Blacks comparatively have lower suicide rates. That's correct. Anyway, let's go back into it. As noted, biologic risk factors include altered serotonin markers. Among psychological risk factors, hopelessness has been shown to be one of the most reliable indicators of long-term suicide risk. Also, when I say blacks have a lower suicide rate, I mean they have a lower suicide rate commitment. That doesn't mean necessarily that they have lower rates of suicidality per se, which I'm not 100% sure on. Recent evidence suggests that suicidal risk may increase in children and adolescents who initiate treatment with antidepressant medication for depression or other psychiatric conditions. It may increase it. SSRIs are said to potentially increase suicidal thoughts. It's very dubious as to whether or not they actually increase the rate of suicide, but they definitely increase, or they're believed to increase, seemingly, the rate of how often people bring up suicide. When they're talking to their psychiatrist, if they're taking an SSRI, they may be more likely to bring up suicide in the discussion. But it becomes a question about whether or not this is simply they're equally likely to think about these things. They're just more likely to bring them up once they get treated with SSRIs. Maybe it's because they are more likely to think about it, but maybe they don't necessarily commit to it. It's hard to say. And maybe they are more likely to commit to it. Again, it's sort of a gray area. But they put that labeling on SSRIs just for people to be aware of the fact that there might be an elevated risk. The details of the association between antidepressant medication treatment and child and adolescent suicidality are unknown. Antidepressant medication prescribing information in the United States now contains a black box warning cautioning providers to assess carefully the risks and benefits of antidepressant treatment in children and adolescents. I think that's still true today. Yeah, I believe so. Providers should also warn patients and their families that suicidal thinking may increase with antidepressant medication treatment, especially during the first few months of treatment. Because antidepressants may also transiently increase suicidality in adults as well, adult patients should also be cautioned regarding this possibility. Periods of initiating, tapering, or adjusting the dosage of an antidepressant medication may increase the risk of worsening depression or suicidality. These periods warrant extra scrutiny by patients, families, and caregivers. 2 medications have thus far shown evidence for reducing suicide risk: lithium, when used to treat bipolar disorder, and clozapine, when used to treat schizophrenia. Abrupt lithium discontinuation, however, is associated with an greatly increase suicide risk for at least 1 year afterward. As such, physicians should be very carefully consider the potentially fatal delayed consequences of psychiatric medication changes, especially lithium and similar mood stabilizers. Clinical manifestations. History and mental status examination, most often a suicide attempt, is self-evident in presentation, either because the patient or family indicates that such an event has occurred, or because there is an acute medical or surgical emergency, that is to say, an overdose or wrist laceration. It is important always to obtain further details from the patients and any witnesses to provide a full history of the antecedents and the suicidal act. Occasionally, a patient will present to a physician in a more subtle way with nonspecific complaints. Patients may also overtly deny suicidal intent, even when prior statements to intimates or caregivers indicate clear suicidal thinking or planning. Careful inquiry may reveal that the patient has taken an overdose of a medication with delayed lethality, such as acetaminophen. Patients who have attempted suicide require thoroughly psychiatric evaluation. Psychiatric history and mental status examination should explicitly address depressive symptoms such as suicidal thoughts, intent, and plans. The details of the suicide attempt are critical to understanding the risk of a future suicide. Patients who carefully plan the attempt, use particularly violent means, and isolate themselves so as to not be found alive, are at a particularly high risk of future suicide completion. Differential diagnosis. Patients who attempt suicide most commonly suffer from depression, schizophrenia, alcoholism, or personality disorders, or comorbidities of these disorders. Patients who do not meet criteria for any of these disorders can and do attempt or commit suicide. However, especially if they have any other risk factors, that is to say, for example, hopelessness. Management. Suicidal ideation should always be taken seriously. Suicidal patients are often fraught with ambivalence over whether to live or die. An intervention and effective treatment can be life-saving. Most actively suicidal patients require hospitalization on a locked unit for their own safety. Potentially lethal items should be held securely by nursing staff, and the patient should be observed carefully for the risk of elopement. Treatment of the underlying disorder or distress derives from accurate diagnosis. Antidepressants or electroconvulsive therapy for depression. Antipsychotics and or mood stabilizers for bipolar disorder, psychotic depression, or schizophrenia. Patients at lower risk for suicide can often be managed as outpatients if close follow-up is available. Family members are supportive and a treatment alliance exists. Frequent meetings with treatment providers eliminating the means of suicide like firearms, potentially toxic prescription pills, and enlisting spouses, partners, or other family members are essential elements of outpatient treatment. Surprisingly, there is little solid empirical evidence to guide clinical intervention targeted at preventing suicide. Although it seems clear that treating an underlying psychiatric condition might reduce the suicide risk associated with that condition, clear data are not yet available regarding the particular efficacy of a given medication or class in this regard, except for lithium for bipolar disorder and clozapine for schizophrenia. Psychosocial interventions targeted at preventing suicide do not have strong research support. Until additional evidence-based findings emerge, the standard of care for suicidal individuals remains hospitalization or other secured treatment alternative coupled to treatment of associated psychiatric conditions. Next section, we're going to go into spousal abuse. So abuse between spouses or partners can take several forms: physical, sexual, and emotional. Physical abuse or battering is most often perpetrated by a male on a female partner, but women do batter men, and abuse also occurs in same-sex relationships. I want to go into that a little bit as well. I don't know if they go into it later, but basically, I believe homosexual male relationships have similar levels of domestic abuse as heterosexual relationships. Lesbians are more likely, in I think in a statistically meaningful way, to have domestic abuse going on. Why? I can't say for sure. We can always speculate as to why, but based on the current evidence, lesbians are more likely to have domestic abuse of their partner or by their partner compared to heterosexual couples or male homosexual couples. So it can be nuanced, I guess you could say. Epidemiology. Spousal abuse is estimated to occur in 2 to 12 million U.S. households. Some studies estimate that nearly 1/3 of all women have been beaten by their husband at least once during their marriage. Many battered women are eventually murdered by their spouses or boyfriends. Okay, so that's a little bit of a sort of a Mon and Bailey situation, a little bit, where they say, many battered women are eventually murdered by their spouses or boyfriends. Well, I would believe if the husband is continuously abusive, then there's a good chance, yeah, that if he's violent and antisocial, then yes. But then they also put in the mod, I guess you could say, the Bailey in the situations, they say, or whatever the characterization is, they use the couch of saying, well, 1/3 of women have been beaten by their husbands at least once during their marriage. So basically, they initiate by saying, domestic abuse includes a guy who hits his wife once, or uses physical force on his wife even once, And again, I'm not saying this is appropriate. I'm saying that this is considered physical abuse, even in this circumstance, because he does it at least once. But then they say, and many women get murdered by their husbands if they're physically abusive. It's like, okay. But now you switched over from guy who hits his wife once to guy who's probably continuously physically abusive to the wife. Or his girlfriend, which is a little bit of a different circumstance, we have to admit. Because it's not like, 1/6 of women get murdered by their husbands or something like that, because 1/3 of them have been beaten by their husbands or girlfriends at some point, been beaten by their boyfriends or their husbands at some point. So it's like basically women are being genocided by men or something like that. Like, no, obviously not. But just be aware of that when they use this term abuse, you have to think, and this is true for any sort of term people use in psychiatry, sociology, the legal system, or politics. Politics is a very common one, and these kind of intersect with that a little bit here. When they use a term like this, are they referring to somebody who is beaten their wife or hit their wife, struck their wife even once in their entire marriage, in their entire relationship? Or are they referring to the frequent abuser? Think about what kind of parameters are they using when they say many battered women are eventually murdered, or when they say 1/3 of women have been hit by their husband at least once. So anyway, according to the U.S. Department of Justice, 37% of women treated in emergency rooms for violent injuries were hurt by a current or former partner. Of women murdered by an intimate partner, 44% visited an emergency room in the 2 years prior to their deaths. Risk factors. There is a strong association between it's actually surprising it's less than, it's only 44%. You would think there would be more. You think it would be less 0 to 100 stuff. To be fair, there's some women who get beat and they don't go to the hospital. To be fair. Risk factors. There is a strong association between alcohol abuse and domestic violence. That's true. More than 50% of abusers and many of the abused have a history of alcohol or other drug abuse. As children, most abusers lived in violent homes and were either witnessed or were themselves victims of battering. Again, also bear in mind, that's partly genetic. So if you are a person who is a violent and aggressive and antisocial, but your dad was the same way, well, your dad is not just exposing you to that environment, he's also giving you half his DNA. So anyway, so it's a combo. It's a complicated, tricky subject, The victims of abuse, more often than not, are also products of violent homes. Pregnant women are at elevated risk for spousal abuse, often directed at their abdomens. Okay. Clinical manifestations. History and physical and also when they said pregnant women, yeah, it's not just his wife, also his girlfriend, also some girl that he had sex with a few times, and it's kind of a situationship thing, or she's like a side hoe, and men and women, I guess you could say both ways, have all sorts of different kinds of relationships with each other, which are of dubious moral quality, Clinical manifestations. History and physical and mental status examination. Many victims of abuse are reluctant to report abusive episodes because they fear retaliation, believe they are deserving of abuse, or do not believe that help will be effective. Victims of abuse are often mistreated in ways that prevent them from escaping the abusive relationship. They are intimidated, maligned, coerced, and isolated by the abuser. Attempts to leave an abusive relationship may be thwarted by financial concerns, the welfare of children, fear of being alone, or the threat of further battering. And that's real too. Definitely. People think about all the same things about why you would not want to end a relationship. Maybe you think, oh, well, maybe I was overreacting. Oh, well, he still provides this much stuff for me. And he is the father of my kid, so forth. And so there are some things that the same things that would tie you to somebody in a relationship could also tie you to somebody in a relationship to somebody who is admittedly not a very good person. It potentially presents a threat to your health and well-being. So anyway, patients may present in the company of their abuser for the treatment of accidental lacerations, contusions, fractures, or more severe trauma. Unless the patient is asked tactfully in the absence of the abuser, he or she is unlikely to reveal the true cause of injuries. That's also true. Physical examination should include examination of the skin for contusions, especially of the face and breasts, and a genital examination. The mental status examination should take into account the appropriateness of the patient's and partner's reactions to the accident. Management. The goal of treatment is to end the violence, that is to say, both partners must agree to treatment, or to enable the victim to leave the relationship. Either option is difficult to achieve. Social agencies must be enlisted to aid in child protection and custody if the latter option is chosen. I would say, though, if the partner who was abusive is also just generally antisocial and probably be dangerous to people around them in other situations besides just this particular relationship, they probably should, have some sort of legal implication. I mean, obviously, being physically abusive may require legal justice regardless, but you don't really want them to be a threat to society or people around them otherwise. Their kids, their a future girlfriend, a future boyfriend, a future whatever. You have to be aware of the fact that this person might be problematic. Patients who refuse help should be told that what emergency services are available and how to access them. Unfortunately, women are most at risk for serious injury or homicide when they attempt to leave the abusive relationship. I can believe that. Yeah. Elder abuse. This is a little bit of a semi-related category. Approximately 10% of those older than the age of 65 are abused. Victims usually live with their assailants, who are often their children. Also, can be they can be aides at homes and stuff like that. People who are at a retirement home, people can be abused by workers who are there as well. That both of these things happen. Mistreatment includes abuse and neglect and takes physical, psychological, financial, and material forms. The abuser may withhold food, clothing, or other necessities, or beat, sexually molest, or emotionally abuse the victim. As with spousal abuse, the elder person is often reluctant to reveal the abuse. Clinicians should be alert to the signs of abuse. Treatment involves appropriate medical and psychiatric services and social and legal services. Some states mandate reporting of elder abuse. Bereavement. Bereavement occurs following the death of a loved one. Diagnostic and Statistical Manual of Mental Disorders, 4th edition criteria limit normal bereavement to a 2-month period following the loss of a loved one. The symptoms of bereavement, such as a sad mood, trouble sleeping, loss of appetite, and ruminating on the loss of a loved one, mimic to some degree those of major depression. When symptoms of major depression predominate, however, or when the following symptoms occur, a diagnosis of major depression should be considered. Symptoms suggesting major depression include 1. Increased guilt not associated with behavior or actions related to the death of a loved one. 2. Suicidal thinking or thoughts of death other than feeling that one has a desire to join the loved one in death. 3. Excess worthlessness. 4. Psychomotor retardation. 5. Severe impairment in ability to function. 6. Auditory or visual hallucinations other than hearing the voice or image of the deceased, which is considered a normal component of bereavement. Treatment for treatment for uncomplicated bereavement is diverse, and there is not sufficient evidence available to suggest that one form of therapeutic intervention is reliably superior to another. In bereaved individuals with depression, antidepressant medication is indicated. Key points. So this is the end of the section. So key points, or end of the chapter. Suicide is a fatal complication of many psychiatric disorders. Hopelessness is a risk factor for attempting suicide. Antidepressants may transiently increase the risk of suicide, although it's debatable. About 1/3 of females suffer spousal abuse. Again, that is to say, at the very least, their husband hit them once at some point in their lives, and therefore, he's being categorized in the same thing as a guy who's, an O.J. Simpson kind of guy, Anyway, about 10% of individuals over the age of 65 suffer elder abuse. Normal bereavement lasts up to 2 months. Antidepressant medications are indicated for the treatment of depression in bereaved individuals. Okay, and that is the end of the chapter, chapter 10. Now, if you stuck around this long, hopefully you found this useful. Anyways, have a great rest of your evening, morning, afternoon, day. Thank you, and goodbye.